Everybody, it's Dr. Tim Schaffner, a bariatric surgeon in Bon Secours, and along with me is Dr. Sid Kudov, my partner, also bariatric surgeon here. And we're giving a presentation on obesity and weight loss options. It's a virtual presentation we've been giving in person. And the reason that we started giving this presentation was that we find that we have a lot of patients who come in, they're interested in weight loss, either medical or surgical weight loss. They've talked to their family, they've talked to their PCP, they've talked to their friends, they've read things on the internet. They spend a lot of time and effort to get a consultation with us, come in and be seen, but they don't really get information from us up front. And so a lot of times we see a patient and we tell them what options exist for them, and what they think those options are a lot different than what they are in reality. So our goal with this is really to educate people at the forefront about what medical and surgical weight loss is, and equally as importantly, what it isn't. And to understand that one, all these tools exist for patients, but to give people all the information they need to choose the correct one at the jump. So we'll start with some background about obesity. The reason that we make all these tools available is the problem of obesity. And obesity is not just the stereotype of a patient who sits at home and eats potato chips on the couch. Obesity is a lifelong progressive disease. It has genetic components. The disease is of excess fat storage, but the goal in treatment is to eliminate the excess fat, but also to prevent the downstream metabolic complications. And we'll get into those in later slides, but there's everything from high cholesterol to cancer to diabetes, all of the things that decrease people's lifespan and their health span. Some definitions about obesity. We use body mass index, and body mass index is nothing more than a function of a patient's height and weight. It is a bit of a controversial term nowadays. The AMA wants people to go away from using BMI because their argument is it's not a very good representation of overall health. And to a certain extent, I agree with that. You may have a patient who will come in and their BMI is 37 and they have diabetes, high cholesterol, high blood pressure, heart disease, etc. And you might have a patient who comes in, their BMI is in the mid 50s and they have none of these things. So the metabolic complications of obesity do not necessarily follow BMI one-to-one. And to me, we have to be aggressive at treating the disease of obesity at much lower BMIs than people may necessarily think. But for our purposes, BMI is still used to define certain thresholds for medical and surgical therapy. For most patients at a BMI of 30 or higher, that unlocks medical weight loss, and at a BMI of 35 or higher, unlocks surgical weight loss. And the slide, I think the statement says it all, that once patients have developed obesity, once these patients' BMI is over 30, if you take all patients, they have less than 2% chance of being able to reach and maintain a normal BMI over their lifetime. And I think that speaks to all of our experience as healthcare providers. It is very difficult to lose weight and maintain that weight loss. So these next set of slides are really telling. So these are self-reported obesity rates by the CDC. They really started tracking this methodology around 2012. And so this series of maps gives us a snapshot of how severely this problem has advanced over the last decade. So this is in 2012. And if you look at here, it looks like we're not doing that bad. The Rockies are, 25% or so obesity rate amongst adults. The Midwest and the South is a little bit higher. New England, there's a lot of green there. But watch what happens as you progress through time. So this is 2012. This is 2014, 2016, 2018, 2020. And the most recent one that just came out or was just published is 2022. So, and the biggest difference between 2020 and 2022, I'll tell you, that's the COVID effect for sure. That's the pandemic. We've seen an explosion of obesity after the pandemic, but it has been an uptrending problem for some time. So that's 10 years. That's 2012, 2022. The last time it was estimated from 2017 to I believe 2020, the overall adult obesity rate nationwide was about 41%. My guess is it's probably higher now. We're certainly not immune from that in Virginia. We're sitting there at a 30 to 35%, 35% or so obesity rate, but that's statewide. And so what we know is there are pockets that are much, much higher than that. We know that lower socioeconomic status is a much higher risk for obesity and obesity-related comorbidities. So you can be sure that there are some pockets of the state, some of which that we live in and have patients that we treat, where the rate is going to be much higher than that. So this is a very old study, but it answers, I think, a very basic question for the patients when they come in. Why do we care that you lose weight? And the simple answer is that you're less likely to die if you lose weight. It's a very old study, 1989. If you take patients, we'll say the baseline is a BMI around 25, and patients up around BMI of 40, compared to a baseline, they have a 2.5% mortality ratio annually. So 2.5 higher time, 2.5 greater chance of dying of all causes throughout the year. And as we mentioned before, it's not simply the presence of excess fat. It's all of these things. It's the downstream metabolic complications that come from obesity. It's the reason that our governing institution, or our parent institution, the American Society for Metabolic Bariatric Surgery, is metabolic surgery. The emphasis is on the metabolic outcomes from obesity: sleep apnea, high blood pressure, diabetes, high cholesterol. Cancer is one that we talk about a lot, and it's talked about at society meetings at length now, the association between multiple different types of cancer and obesity, not least of which is ovarian, breast, colon, but also the decreased incidence of cancer in patients who have undergone weight loss surgery, significantly improved compared to a comparator group that did not undergo surgery. And it's for this reason that I talk extensively about required cancer screening with patients when they come in for a consultation, because I think it's hypocritical not to. It's hypocritical to talk about, I want to improve your diabetes, I want to improve your blood pressure, your cholesterol, but to ignore their cancer risk, knowing they're at an elevated risk, I think is really important. This study is something that I think is less intuitive to the patients that we talk about a lot, is the difference between diet and exercise. What is the greatest component of each to weight loss? A very simple study, broke up into 4 groups. Control group, group that dieted and exercised, a group that just dieted, and a group that exercised, and see how much weight each group lost. So I don't think it's a surprise that the control group didn't lose much of anything. And I don't think it's a surprise that the group that dieted and exercised lost the most amount of weight. But the surprise is really in the middle. The group that just dieted didn't lose much less weight than the group that dieted and exercised. And the group that only exercised and didn't change their diet at all didn't lose much more weight than the group that did nothing. And so the takeaway to that for me is it is the diet. The diet is the primary mechanism for patients to lose weight. We get a lot of patients who have degenerative joint disease, who are not very mobile, certainly not as mobile as they used to be. And they'll say, well, I'm not able to exercise, so I can't lose weight. My response to that is usually, yes, you can. It may be harder, and we certainly think exercise is important, especially after surgery. But the key is the diet. The key is the diet. That is what either medicine or surgery will force the patients into, is decreased caloric intake. Calories in, calories out, and it really boils down to that. So how do patients decide, what direction they're going to do? How are they going to lose weight? Are they going to just diet and exercise? Are they going to try medications? Are they going to try medications and a combination of a very low calorie diet? Are the patients going to have surgery? How does a patient choose between those options that we offer? And the short answer is it's not a short answer. The answer is that it depends on a lot of different things, and it depends on things that are different for every patient. So We talk to people a lot about individualized therapy. What is right for one patient is not necessarily right for another. How much weight do patients need to lose? That's a very practical consideration. But what is their weight loss goal? Because these are not equivalent therapies, as we'll see in some of the case studies at the end. You have other medical issues that need to be addressed. Are these medical issues that are better addressed with medication? Are they better addressed with surgery? What does your insurance cover? Does your insurance have a bariatric surgery rider? Does your insurance have coverage for pharmaceutical options? What's the urgency for weight loss? We've had a number of women who come in who are trying to preserve their childbearing years that don't really want to have conservative therapy for several years. They want to lose weight as soon as they can so they can give birth, and that's totally understandable. What can you afford? What's the out-of-pocket cost of surgery? What's the out-of-pocket cost for medications? And the answers to these are different for virtually every patient. But the takeaway is that we offer all of these different options to patients. We're going to touch on some of the data about weight loss surgery. It's certainly not an exhaustive list. Some quick facts about weight loss surgery. The first bullet point is maybe the only bullet point that matters. Bariatric surgery, in particular, reduces the patient's risk of premature death by 30 to 50%. And in some cases, that might be an underestimate depending on an individual patient and the number of metabolic comorbidities they have. But in virtually every patient, it does decrease their risk of dying of these comorbidities in early age. We'll present some numbers on this in the end, but also the majority of these patients that have these metabolic comorbidities will experience remission of these with successful weight loss. Diabetes is a big one. And we talk about that with the third point that a lot of these randomized trials show, especially in gastric bypass or duodenal switch to a certain extent as well, these patients that have diabetes can have complete remission of their diabetes or improvement of their diabetes that can be seen even before they leave the hospital. Patients who have mild to moderate severity of disease, especially patients that have not required insulin for their diabetes, they may leave the hospital after surgery off of all medications. And it's really a tremendous response that we've seen a number of times throughout our career, where a patient's blood sugar just goes down to 100 the day after surgery. They're not on any medication. They're not getting any insulin. It's clearly before they've lost any weight. And that's owing to the hormonal changes that happen with bariatric surgery, upregulation of hormones like GLP-1, GIP, that produce a very vigorous response early on. And it's for that reason, we'll talk about some of the diabetic data, that it is really the most powerful therapy for patients with diabetes and obesity. This study is, I think, from 2016, 2017, is Dr. Shower's study, Cleveland Clinic. This was the New England Journal of Medicine. There's a lot of data on this slide. I'll kind of cut through it. This is 5-year outcomes, randomized controlled trial comparing bariatric surgery to aggressive medical management of patients with diabetes. And it was very aggressive. Their endpoint for medical management was a hemoglobin A1C of less than 6. So they were throwing everything but the kitchen sink at these patients, including diet, exercise, medical management, to try and get their A1C as low as possible. And they compared that to patients who had surgery. And the results were not particularly close. If you look here at the A1C response, now clearly the patients that had the medical group responded, but not as vigorously as the patients that had surgery, both sleeve and gastric bypass. And that response persisted for out to 5 years after the study, that it remained superior. You look at the medications the patients were on, the patients that had medical therapy generally had an escalation of the therapy. They were on more medications. It did work, but it took more medications to do it, as compared to surgery, where these patients were on fewer medications with a more robust response. In the case of gastric bypass, almost 50% of those patients were on no medications whatsoever during the study period. In addition to that, the patients that had surgery lost weight. That's not a real big surprise. Certainly more weight than the patients in the medical group lost. So multiple medical societies, including the American Diabetes Association, recommends bariatric surgery as a first-line therapy. really for patients who have uncontrolled diabetes and obesity, especially those to us who have had a shorter term of diagnosis. The longer term of diagnosis the patients have had before surgery, the less likely it is to go into remission. When we get a patient in here, they were diagnosed a year, 2 years ago with diabetes, I tell them that it's an almost certainty that they are going to go into remission after surgery and weight loss. Looking at the medical side of things, tirzepatide was recently approved as the first combination GLP-1 GIP agonist for weight loss. It's been out as Mounjaro, and now it has been branded as Zepbound for obesity. So I would consider this as best case scenario for medical treatment of obesity right now. This has been the most robust response that we've seen. And this was the New England Journal of Medicine article from last year. They treated these patients for 72 weeks and followed them. The total percent body weight change was 19.5%. For patients who are on the 10 milligram dose, and patients who were on the highest dose, 15 milligrams, it was just shy of 21% total body weight loss. GI symptoms were pretty much similar with what we see with Ozempic, Wegovy, nausea, vomiting. A few patients that had acute cholecystitis that required discontinuation. But the study patients also had significant improvements in their cholesterol, their fasting insulin, and their diastolic blood pressure, as well as weight loss. The average BMI in this study was around 38. We talk a little bit about the controversy with how they define obesity in these studies. I'll skip around a little bit. The question of total versus excess body weight loss. So I included this slide because it's important to understand how we advise patients, especially patients at a higher BMI, in terms of surgical versus medical weight loss. Part of the problem is how the data has been collected. So there is somewhat of a bias in the surgical literature where patients' weight loss after an intervention in surgery is measured as the percent excess body weight loss, whereas in the medical studies, it tends to be measured as the percent total body weight loss. The problem is that those two are really apples and oranges. They're not one-to-one comparisons. Very difficult to draw any conclusion from the total body weight loss and compare it to surgery. And I give this example, which I think demonstrates why. So as a patient's weight goes up, the percentage of that weight that is excess body weight also goes up. So when we advise patients on surgery, we're giving them these estimates. Like if you take tirzepatide, you might lose 21% total body weight loss over the course of a little over a year. So in a patient whose BMI is about 40, their excess body weight is measured at 88 pounds. That patient at 21% total body weight loss might lose 44 pounds. And after a bypass, so we usually quote 70% excess body weight loss, might lose 61% pounds. So it loses, you see that this is about 2/3 of this. Now you take a patient at the opposite end of the spectrum, whose BMI is in the mid to high 60s, excess body weight is 283 pounds. Now with a 21% total body weight loss, we're talking about 87 pounds. We're also talking about around 200 pounds with the gastric bypass. And so that difference becomes more stark as patients' BMIs increase. A lot of these medical trials don't have a lot of the very high BMI patients enrolled in them, as the surgical trials do. So it's for this reason that if patients come in and they have higher BMIs, we typically talk to them more about surgery because the difference in surgical and medical treatment is so stark as their BMI comes up. I have one more slide. The reason that I've included this slide in the past is because we get a lot of questions about weight regain after bariatric surgery. The patients will say, I'm gonna lose weight and I'm just gonna regain it. And this is what I tell them is what they can generally expect. And so this is a longitudinal study, a lab study. They followed a lot of patients, over 2,300 patients, and they followed them for 7 years after surgery. And so you can ignore the orange line because we don't really do gastric bands anymore. But this dark line is gastric bypass. So this is what their weight does. And I like this because this curve is almost exactly what I tell patients to expect. Now, people can gain weight for a lot of reasons. But what I tell people to expect is their weight to decrease from their baseline until about a year to a year and a half, where it's going to bottom out. And then after that, it's going to come up a little bit, because that's what most patients do. They go down, they bottom out, they come up a little bit, and they generally stay right there. And that's what you see happens. The patients bottom out, they come up a little bit, but out to 7 years after surgery, they're still far below their baseline. And in a normal case, that's exactly what patients can expect. All right, at this point, I'm going to turn it over to Dr. Kudov and let him describe the medical and the surgical options here.
I'm Dr. Kudab, one of the surgeons here at Secours as well. So I'm going to cover the second half of our discussion today and try to give an overview of some of the options we offer in our practice. Our meal replacement interventions are medically prescribed meal replacements that are designed to deliver complete nutritional benefits to patients who are using these interventions. They're more than just calorie restrictive. They're nutritionally balanced. Following this requires supervision, follow-up appointments, and tracking your body composition. Multiple studies show improvements in body weight as well as body composition. Now, this intervention is likely to be most noticeably effective in patients with a lower degree of obesity or excess weight, but can be helpful for anybody. Some of the most commonly used medications to address obesity include Contrave and Phentermine. Contrave is a combination of two other medications, bupropion and naltrexone, which are typically medications that are successful in helping and treating smoking cessation as well as drug addiction. Contrave can be very helpful for patients who have food addiction behaviors, binge eating, or significant cravings. The weight loss outcomes with Contrave can vary based on the severity of obesity and obesity-related problems. Phentermine is an appetite suppressant. Phentermine typically allows greater weight loss than with diet and exercise alone. It works with diet and exercise, not to replace it. It can be habit-forming, so for patients with a history of substance use disorder, Phentermine may not be the right choice. We also avoid using Phentermine in patients with significant heart disease or increased blood pressure because the most common side effects of Phentermine include higher heart rate, increased blood pressure, restless legs, and insomnia. Similar to Contrave, the weight loss benefit with Phentermine can vary depending on body mass index, severity of obesity, and obesity-related problems. The relatively newer medications for obesity management called GLP-1 agonists have generated a lot of buzz in obesity management strategies. Now, this medication typically is an injectable or sometimes an orally taken medication designed initially as diabetes management, but also with indications for obesity management as well. Using this medication, patients with varying degrees of obesity can expect, on average, improved weight loss compared to the appetite suppressant medications. The results can similarly vary based on the degree of obesity and obesity-related problems. The results of the clinical trials under ideal circumstances can show weight loss between 8 and up to 16 to 20%, depending on the study, of total body weight. In the real-world intention to treat data, the results tend to vary a little bit more when utilized outside of the parameters of the initial clinical trials. Weight loss tends not to be to the same degree as found in the trials, but still significant for many patients. The GLP-1 medications can be relatively expensive and are hard to afford out of pocket without insurance coverage. Insurance coverage for these medications can also vary depending on patients' initial weight as well as medical comorbidities, as well as based on the treatment response using the medications appropriately. So let's start transitioning to talking about some surgical options. As Dr. Schaffner mentioned, depending on the patient's overall comorbidities, degree of metabolic dysfunction, the treatment options have to be tailored to those patients. And so typically we start thinking about surgical options when we have seen that the more conservative strategies have failed those patients in terms of effectiveness and durability. So when we talk about diet and exercise, we know there's no replacing that. And most of the patients, when they start considering surgical options, they have tried countless dietary strategies, commercial dietary products, exercise programs, and the like. And when those patients have tried each of those routines, have maybe had some weight loss or not, most importantly, been unable to maintain whatever weight loss they achieved, then we know that their metabolic function is declined to a degree that we have to consider more powerful therapies, such as surgical options. We typically are going to consider surgery in patients where we know that the risks, or at least where we suspect strongly, that the risks of the surgeries are lower than untreated or suboptimally treated obesity. And Dr. Schaffner presented some pretty compelling data in that regard. We know that over the last 5 to 7 years, there have been a number of studies that demonstrate improvements in all-cause mortality after bariatric surgery compared to non-surgical treatment options. We know that in some studies that shows that in patients with diabetes, that the life expectancy can increase an average of 9 to 11 years. And for non-diabetic patients, the life expectancy after bariatric surgery can increase by anywhere between 4 and 6 years. That also demonstrates how bad of a player diabetes is in terms of long-term mortality and morbidity risks. So if we can utilize a treatment strategy for obesity that also significantly improves metabolic function, decreases the comorbidity of diabetes in terms of putting it in remission, we know that not only are those patients going to have a lower cost in terms of out-of-pocket expenses and insurance expenses for themselves, but also have a longer life expectancy and typically a better quality of life as well. We also consider surgery for reasons that are not always necessarily directly for changing numbers on the scale. So most of our patients, and this may be due to cultural factors, most of our patients are women. And women of childbearing age who struggle with severe metabolic dysfunction oftentimes come with coexisting polycystic ovarian syndrome, fertility problems, and irregular menstruation. And so for many women, obtaining a healthier overall health, obtaining a better balance for your health, and improving body weight and metabolic function can also improve fertility and allow women to start their families at ages that are safe for them and in a scenario in which their overall health is also improved. There are also studies that demonstrate the power of epigenetics when it comes to obesity. Obviously, we know that obesity has genetic predisposition and certainly the environmental factors that can lead to that predisposition becoming a reality. But we know there are epigenetic factors as well. And so there are studies that demonstrate that children born to women who had had bariatric surgery have a lower risk of adult obesity and diabetes as well. And so clearly the hormonal and metabolic milieu in which those children are developing in the womb seems to have a prolonged effect on the course of their lives as well. For some patients, they struggle with other comorbid issues that surgery can directly impact as well. So if we have patients who have severe obesity as well as severe acid reflux, we can treat those patients with one surgery in some cases to address both situations. And that's something that, as of yet, the medications tend not to be able to address altogether. So again, this is about tailoring the treatment strategy to each patient based on their current health, about the considerations about their future health, and what other medical issues are going on as well, and how can we best address those issues in as cost-effective and a safe way as possible. Now, these are the procedures that we offer in our practice. Far and away in the United States, the sleeve gastrectomy is the most commonly performed bariatric surgery. The sleeve gastrectomy is a stomach procedure primarily. It is a procedure in which we remove the majority of the stomach, leaving the stomach as a much narrower conduit, about the size and the shape of a banana, resembling a shirt sleeve, which is why it's called a sleeve gastrectomy. Sleeve gastrectomy involves no implantation of any devices. Given that it is a stomach-only procedure, there's no intestinal reconstruction with a sleeve gastrectomy, which means that it is a fairly efficient procedure in the operating room and minimizes time under anesthesia. It also comes with a slightly lower risk of intestinal blockage, dumping syndrome, and vitamin and nutritional deficits long-term than the intestinal procedures that we'll discuss next. One of the major variables when it comes to sleeve gastrectomy that we advise all patients about is that there is a variable risk of some degree of acid reflux. So sleeve gastrectomy does have a variable risk of acid reflux. And so we screen all of our patients at their consultations and during our workup for acid reflux so we can make a surgical decision with those patients that makes sense. The next most commonly performed bariatric surgery in the United States is the gastric bypass. The gastric bypass has been around for decades. It has been studied for decades, and it is a pretty well-established and the data around the gastric bypass is very robust. The gastric bypass is a procedure in which we make a small stomach pouch, disconnecting the majority of the stomach from that stomach pouch, and then connecting that stomach pouch to the small intestine. So food would then skip the majority of the stomach and a short distance of the early small intestine. So with a sleeve gastrectomy where we operate on the stomach with no intestinal reconstruction, gastric bypass involves a stomach procedure as well as an intestinal reconstruction. That does add a bit of a metabolic effect to the gastric bypass compared to the sleeve gastrectomy, in which patients tend to have a slightly higher weight loss with a gastric bypass and weight maintenance as well. But it does come with some additional considerations that anytime you reconstruct the intestinal tract, that can change function to certain degrees in certain patients, that can introduce a small risk of bowel blockage, but a risk nonetheless, and a risk of vitamin deficiencies if patients are not reliably taking their daily multivitamin, as well as maintaining good nutritional habits with natural whole food type diets. And then the other two procedures that are worth discussing are the duodenal switch, as well as the modified duodenal switch. So the duodenal switch is essentially a combination of techniques utilizing a sleeve gastrectomy as well as a more aggressive intestinal bypass than a gastric bypass. So a duodenal switch involves a sleeve with a bypass. In a duodenal switch, on average, we bypass about 50 to 70% of the intestine. So it is a more aggressive surgery than the gastric bypass or the sleeve gastrectomy. With the duodenal switch or the variant of the duodenal switch, which is called, again, the modified duodenal switch, it goes by a bunch of names. It also goes by the SADI, S-A-D-I, which is a single anastomosis duodenoileostomy with sleeve gastrectomy. It also goes by SIPS, which is a stomach intestinal pylorus surgery. So there are a lot of names, but essentially the modified duodenal switch is a simplified version of the traditional duodenal switch, which maintains the majority of the weight loss and metabolic effect with a simplified approach with one anastomosis or one connection in the intestine versus two. We go over these procedures with patients in whom we think it is a reasonable option, but given that it is the most aggressive option that we can offer, and that it does absolutely require lifelong complete adherence to vitamin supplementation and long-term indefinite follow-up with our team and our bariatric dietitians, we are quite selective about this procedure as much as we need to be. Okay. But the outcomes, of course, with the most aggressive surgery are also going to be the highest weight loss and the highest remission of metabolic dysfunction. Now, typically, when we talk about bariatric surgery, we have to keep in mind the historical perspectives as well. And in decades past, when bariatric surgery was in its earlier stages of innovation and standardization, the technologies utilized at the time, the understanding of the anatomy, the standardization of practice, the understanding of nutritional habits and supplementation, the requirements for lifelong nutritional follow-up, these really hadn't been at a level that led to the best outcomes in the infancy of our field. However, over the last 20 years, honestly, the improvements in technology that we utilize to do our procedures, standardization of techniques, the robust data that has been collected and published over the last 20 years have all led to, honestly, quite remarkable improvements in the safety of the procedures that we offer. So the risks of major complication, the most major of which being mortality with bariatric surgery, even with older data seen here, show that the risks of mortality with bariatric surgery are far lower than some of the most commonly performed procedures in the United States. So the risk of mortality based on this individual study with bariatric surgery was about 0.13%. And the risk of mortality with something as commonly performed as a hip replacement was closer to 0.93%. So we see a significantly lower risk of mortality with bariatric surgery than some of the most commonly performed surgeries in the United States. Now, that doesn't mean that there aren't certain risks, of course. So with each consultation with each patient, we review the surgical options, the individual and nuanced risk profiles of each of the procedures, and make sure that the patients have been presented that information as we make decisions with them. We discussed earlier that with sleeve gastrectomy, one of the main variables that's most likely to be seen in any bariatric practice is the minority of patients with a sleeve gastrectomy who may develop some degree of heartburn and acid reflux. With gastric bypass or with duodenal switch, we know that any intestinal reconstruction does come with some risk of vitamin deficiencies, nutritional deficiencies, and bowel blockages. A little bit more unique to gastric bypass is a risk of an ulcer. And so there are certain medication needs and comorbid conditions that may make us lean toward one surgery versus another to try to optimize the treatment strategy, as well as allow a lower risk of future complications in light of other medical issues as well. One of the most common things that I think all physicians who treat patients with obesity need to know is that in gastric bypass patients, utilization of non-steroidal anti-inflammatory drugs is a major risk factor for developing ulceration. Similarly, steroid utilization, systemic steroid utilization can do the same. And so these things have to be navigated carefully when it comes to some of the procedures. Now, when we look at complication rates with bariatric surgery from all from all procedures and from all complications, the risk of major complications can vary depending on the procedure. But the main take home from this slide is that as we escalate the complexity of the surgery and thus the power of the surgery, it also does bring with it an increased risk of certain complications. Now, we're fortunate to say that in our most recent site reaccreditation for our bariatric program, being that we are a comprehensive accredited center through the American Society of Metabolic and Bariatric Surgery and the American College of Surgeons, that our outcomes across the board have been outstanding in terms of all-cause complications with our procedures. Now, after bariatric surgery, we see significant improvements, remission, and reduction of a number of comorbidities. The most common comorbidities that our patients suffer from include hypertension, hyperlipidemia, respiratory dysfunction in various ways, be that asthma or sleep apnea or obesity hypoventilation syndrome. We see significant improvements in cardiac function as we improve each of those other factors. If we improve hypertension, improve diabetes, improve cholesterol, improve arthritis, improve respiratory dysfunction, it goes without saying that those patients are going to have better cardiac outcomes as well. And in many patients, depending on the type of procedure, we may be able to significantly improve obesity-related physical maladies, including joint issues, acid reflux, stress urinary incontinence, and issues like that. Now, we can delve into a couple of real-world case studies. We'll talk about a hypothetical patient, Bill, who's 55 years old, who has type 2 diabetes, sleep apnea, and acid reflux. He's 6'2" and weighs 300 pounds, which gives him a body mass index of 38.5, making him fulfill a diagnostic criteria of class 2 obesity. And so when we look at different strategies, non-surgical approaches, depending on the patient's responsiveness, can typically anticipate weight loss anywhere between 30 and 60, maybe up to 65 pounds, depending on the medication or the meal replacement strategy. With surgical approaches, Bill, with his general medical history, with a sleeve gastrectomy, on average can expect to lose somewhere around 72 pounds. With a gastric bypass, on average, a patient who resembles Bill may lose about 91 pounds. And with a duodenal switch, we can expect about a weight loss of about 112 pounds. Hypothetical patient Tasha is 39 years old with acid reflux and joint pain. She's 5'1", weighs 220 pounds, which gives her a body mass index of 41.6, which is class 3 obesity. So Tasha also, similar to Bill, qualifies for each of the treatment strategies we've discussed today. With the non-surgical approaches, depending on meal replacements, adherence to diet and exercise, and or certain medications, Tasha can reasonably expect to lose somewhere between 20 and 45 pounds. With a sleeve gastrectomy, she can expect to lose around 64 pounds. With a gastric bypass, around 77 pounds. And with a duodenal switch, around 91 pounds.